So thank you all for joining the Global Child Health Lecture Series. Today we have two speakers, both from Associate Professors in Emergency Medicine. Dr. Carol Chen is an MD and MPH. She's also affiliate faculty of the Institute for Global Health Sciences and co-director of the WHO Collaborating Center there. She did her pediatrics residency at UCLA and pediatric emergency medicine and health fellowships at Baylor. She also obtained her master's in public health from Johns Hopkins and has worked with the African Federation for Emergency Medicine since 2016 and leads an international group of experts to create freely available curricula to train providers across the African continent in pediatric emergency care for critically ill and injured children. She also works very closely with colleagues in Tanzania and Liberia with grant funding from the Hellman and Doris Duke Foundations, and works closely with the WHO as well on many of their basic emergency and critical care initiatives. And Dr. Nick Glomb, also MD, MPH, associate professor as well, specializes in pediatric emergency medicine, global health. His research and academic focus is on the safety of pediatric EMS transport and disaster preparedness. Dr. Glomb is a member of the Pediatric Emergency Care Applied Research Network, which is PCARN, and is lead for infectious disease, the CVRN focus group. And thank you both for being here. It's really a pleasure to have you.
Great to be here. Nice to see everybody. I'll go ahead and share the screen. That's not what we want. There we go. Great. Yeah, I'll start off. Maybe we'll just give a little bit of additional information. Carol, you and I can give a little information about how we got to where we are. I was actually in undergrad. I actually studied business and I was a marketing major, and my first job was in advertising in Washington, D.C. And while working in DC, I just didn't feel like I was getting satisfied. And I had always thought about working abroad and ended up working or signing up and applying for the US Peace Corps. And so I ended up working, or I was accepted and worked in Mauritania, West Africa with the Peace Corps for 2.5 years. And this is about a year after undergrad. And while I was in Peace Corps, I did a lot of community health education and started to work with physicians working in global health. And that kind of just was the spark for me to kind of pursue a career in medicine. And so I went into medicine. I had to go back, take all my prereqs for med school, et cetera. But even, starting in med school, in residency, fellowship, global health has been a huge part of what I do and the reasons behind me being a physician and provider. I continue to work abroad, including working in Uganda, helping with curriculum development for their emergency medicine residency program there. And yeah, just really great to be part of the UCSF system. Carol?
Hi guys. Thanks for that intro, Teresa. Yeah, so I did not start out in advertising, but I but I did kind of come to this a little bit in a circuitous route. After I finished peds residency, I worked actually as a general pediatrician for about 5 years before doing fellowship. Our family ended up moving abroad, so I lived in Hong Kong for about 3 years and got the opportunity to work with some different organizations, including MSF, or Doctors Without Borders. And I did some disaster relief for International SOS and kind of worked throughout Southeast Asia and Africa. And so that's kind of what sparked my interest, both in PEM and in global health. And that's how I ended up at Baylor with Nick in this combined fellowship of PEM and global health together. And that's sort of always been, that's kind of what started the passion and got me on that route 5 years later. So just also a shout out to those of you who are in medical training and may not know what you want to do initially and kind of wander around for a few years. That's totally fine as well. And yeah, now I've been working most recently with the WHO Collaborating Center, just like Teresa has been, and with AFEM. And I'll talk a little bit about our curriculum development work with AFEM, or the African Federation for Emergency Medicine. With that, I think we can get started.
Yeah, great. Excellent. Well, so as Carol just said, we're going to be talking about developing medical education projects in low resource settings. Both Carol and I have had some extensive experience working in this field, and would like to share our experiences. So we don't have any, no conflicts of interest. We have received funding for our project. So for the Botswana project you're going to hear about, we did receive funding from Texas Children's Hospital, Baylor College of Medicine, and then received support from the Botswana Ministry of Health and the Department of Accident and Emergency at Princess Marina Hospital in Gaborone, Botswana. And then for Carol's work in Tanzania and in Liberia, she has funding from the Hellman Fund and the Doris Duke Fund. All right, so regarding goals and objectives for today, we do want to just discuss general principles of curriculum development and then how to relate curriculum development to medical education. And specifically, we're going to give examples of our two projects, one an EMS training program developed in Botswana, and another one, the AFEM project in Tanzania and Liberia. And we'll discuss the factors influencing global health work and offer some thoughts about building a career in global health. And then for objectives, we'll list the different steps in curriculum development, the different considerations that need to be considered specific to medical education and curriculum development, and then describe the importance of bidirectional partnerships as you develop your program. So we already did our intros, so let's get right into it. So the Botswana, I started in 2012, my fellowship in pediatric emergency medicine at Baylor College of Medicine with Carol. And that's really when I started this, the background looking into developing EMS training in Botswana. So back in 2012 or prior to 2012, the Ministry of Health in Botswana had no public ambulance system. There was absolutely nothing. So you just had to rely on taxis or public transport to get to hospitals. And so because of the potential and preventable morbidity and mortality by not having an EMS program, the Ministry of Health decided to fund one in 2012. And so they started off by initially funding 8 different emergency medical services or EMS centers across the country. They now have more than 20, which at that time had approximately 150 providers serving a population of about 2 million. And so the Ministry of Health really identified deficiencies in those new EMS providers in their basic resuscitation skills, specifically with pediatric patients. And keep in mind, so these, when the Ministry of Health developed the EMS program, they basically pulled healthcare providers from all different parts of the healthcare system. So you may have like a surge, like a nurse working in the OR that was pulled, and all of a sudden the next day they were told they were going to be a pre-hospital provider. So you can imagine the anxiety and the lack of training that they would have. So through ongoing collaboration between Princess Marina Hospital, which is the main referral hospital in the capital city, Gaborone, and Texas Children's, we developed a relationship with the Ministry of Health EMS director, who's at that time was Major Laba, who had requested for our team to develop a training program for the EMS providers. So Major Laba, he was appointed the EMS director back in 2012, right when the EMS program developed in Botswana. And he was the first paramedic in country, and really the only paramedic in the whole country of Botswana at that time. And so he personally, he became involved in the EMS field or pre-hospital field. He had a personal tragedy where his youngest daughter, who had a history of asthma, had a severe asthma attack. At that time, as I said, there were no EMS services available in the country to assist her during that acute exacerbation. And unfortunately, he couldn't get her to the care that she needed in time, and she passed away. So incredibly sad. And at that point, he then decided to really devote his efforts and career to making sure that that situation would not perpetuate itself. So these are some photos from the Botswana EMS training. You have Major Laba, who's in the light blue button-down shirt, standing next to me in the photo. And right now we'll have Carol is going to talk about, give a little bit of background about her work with curriculum development in Tanzania.
All right. So this is just a little bit of background about kind of where we started. So the African Federation for Emergency Medicine, or AFEM, it's this pretty large organization. It has over 2,000 members, and it represents many countries across the African continent with this goal of sort of advocating for quality emergency care across the continent. They do this through things like educational initiatives, like developing curricula, is what we're going to talk about, but they also do this through sponsoring trainees, through advocacy with ministries of health in different governments. You can go ahead and, I think this is an animated one. You can click, Nick. Thank you so much. And why this is really important. So kind of you can see from this population pyramid that really in sub-Saharan Africa, your populations is skewed towards a younger population. So really the critical and emergency care of kids is going to become has become and is still kind of moving towards an even more important area. How do we really improve the care for these critically ill and injured kids? You can see on the map to the left, these countries are highlighted for their formal emergency medicine training programs, although this is a little outdated and there are a couple more that are not represented on here. But in terms of ones that are specifically focused on pediatric emergency medicine, there's really only one, and that's a combined pediatric critical care and emergency medicine fellowship in Kenya. Next slide. All right. So here you can see there's these are some of our members of AFEM. Here, this is the first class of emergency medicine residents in Tanzania at their national referral hospital in the capital city of Dar at Muhimbili. We're going to talk a little bit more about that later on. You can go ahead to the next slide.
All right. So I just wanted, for those of you that have not been a part of curriculum development, we just wanted to provide some background just in general about how to develop an educational curriculum. So in order to develop a curriculum, it's necessary that you take a systemic approach to ensure that all the local needs of whatever program you're developing are met, as they're going to really differ based on the population and the needs of the learners that you're working with. And so Carol and I both use what you see here as Kern's model for curriculum development. And so just give you some background. The first step starts with the problem identification. And this is identifying through a needs assessment, through somebody coming to you saying, hey, like this is a problem. It could be you just witnessing, you're working in the emergency department or in a hospital, and you notice that there's some type of deficit that you want to address and feels needs additional training. So then the next step leads you to the needs assessment. And that's going to be really targeting the learners that you eventually be training, followed by developing, eventually after that, doing the needs assessment, you'll develop your goals and objectives for the curriculum. And we're going to take you through each step of these for our programs. And then you develop educational strategies for your specific program. And then you want to follow through, obviously, with the implementation of the training. And then critically important that you do evaluation and feedback of the program, so you understand if you're meeting your mark, if you need to adjust your training. And so, as I said, we're just going to share some examples of how we did this for our respective training programs. So let's start with the needs assessment. So as I said, it's a critical step in curriculum development. You really need to look specifically at your group of learners and understand well their background and the different gaps in their knowledge. So for me, with the EMS project, we had people that worked in healthcare that had never worked in the pre-hospital setting. So we knew that we were starting with a really relatively low level of knowledge of pre-hospital medicine. And then you want to identify all the existing resources, and really important, critically important, to identify the key stakeholders. And so this was not just, the availability of the staff in the ambulances, but really what equipment was available in the ambulances, what are the available resources to the EMS team, and what resources are available in the hospital. And so if you have intubation supplies in the ambulance, but you don't have any ventilators in the hospital that you bring the patient to, that may not be a targeted training that you want to focus on. So it's really important that the messaging, so when it comes time to deliver your education project, and really, you're developing a relationship with these key stakeholders, because it's going to be these key stakeholders who in the end ideally are going to be sharing and teaching the groups that you are training, instead of yourself coming from the outside, standing up and training them. And then your stakeholders are going to really help in keeping your plans grounded and realistic. So again, that the time and energy that you put into that needs assessment, I can't stress enough. It's going to be incredibly important. We accomplished our needs assessment through a mix of surveys, written surveys, focus groups, and really in-depth interviews, trying to understand the specific demographic of the population that we are going to be providing, and that particular population, and the specific needs of the EMS providers there. To assess, for the Botswana project, we assessed educational needs for pre-hospital providers in the Botswana EMS system. And so again, we did that by reviewing different EMS data that was available to us. So by the time we started the project, which was in 2013, we had about a year's worth of EMS response calls in Botswana. And so we looked at what the pre-hospital team in Botswana, what type of calls were they responding to? What type of cases did they have to see on a regular basis? And then we analyzed different trends and common response calls for both pediatric and adult patients. And then looking at those specific response calls, we looked at the potential skills required by the EMS providers, and what we need to focus our training on. So the surveys, we did surveys of the providers, and had held focus group interviews of the EMS providers to further identify gaps in knowledge and skills, and really to identify different opportunities for additional training. And this was incredibly critical for the Ministry of Health EMS team, given that, as I said, many of these they weren't paramedics. Many of the EMS providers had been working in different backgrounds and had no true pre-hospital experience. The data for the data analysis and demographic investigation, what we did is we took a convenience sample from those 12 months, so prior to the year before we started working on this project. So we took a convenience sample of those, and then extracted calls from the main EMS center in the capital, Haberene. And this is all written. These are written logbooks and written response calls. So it's like going through paper charts. It's incredibly laborious. We analyzed the following variables. We looked at the age of the patient, the sex of the patient, the time of the call, the chief complaint for the call, any secondary chief complaints, and then the priority level. They would assign an acuity level, and then where the patient was delivered to, and whether it was a call out or a transfer call. And then we did chi-square tests used to analyze this data. So what we came up with, these are the results of that EMS analysis. We looked at EMS chief complaints for pediatric and adult response calls. And then based on the available equipment, we identified applicable skills trainings that would be needed for these response calls. And so some of these skills would be helpful were identified as as desired for additional training, were placed on hold. So something like intubating or defibrillator, we did not focus on those because we knew that we didn't have defibrillators. We knew that we didn't have ventilators. So we just put that type of training on hold. All right. And now Carol's going to share some of her experience with her needs assessment.
Yeah. So, and just to kind of go back and stress and just amplify some of the important points that Nick made earlier around that, that having a structured curriculum development process that he kind of showed you, that published work by Kern and their group. It's really important. I think when you start out, I think sometimes we kind of rush the beginning parts of it, thinking that we're just kind of get going. But I think, like he said, having those relationships and starting out and making sure that your priorities are your partner's priorities are always going to be the most important part. So for our project, as I mentioned before, there was recognized the sort of lack of sort of formal pediatric emergency medicine and critical care training. And so one of the things that the members of AFIM had identified was a need for a curriculum for that. And that sort of speaks to that first piece of problem identification. And so part of what we did for a needs assessment was very similar to what kind of Nick described in the EMS setting, is kind of come at it from different angles. One is sort of collecting data around ED visits for kids in the emergency department. So we did this since Tanzania was going to be our first initial site. We collected this data from the Tanzania emergency department to find out what were the diagnoses that they were seeing in their critically ill and injured kids. And then secondly, looking at this from a qualitative perspective to say, hey, interviewing providers, people who are actually taking care of these kids on the ground. What are you seeing? What are some areas that you would really like some help in? And I think, again, the training there, I mean, it's a variation. Like I said, they have an emergency medicine residency program. So sometimes you're talking to residents in the program, but they also have what we call registrars that work in the ED who don't have any specific specialized training. And so are seeing this from a slightly different angle. And if you could click again, Nick. So what we found when we looked and we compared this data is, interestingly, when you look at sort of the quantitative versus the qualitative, there's actually a pretty good match. So what people are saying they think they need is actually what is happening on the ground in terms of what they're seeing in terms of really sick kids. So 8 out of the top 15 diagnoses were actually matched with what people actually identified through interviews. So those are areas that we knew that we would need to target when we developed this curriculum. Next slide, please. And then another thing that we did in the needs assessment is kind of drill down, and this speaks to what Nick was saying before, is getting a sense in your needs assessment of yeah, okay, we can pick topics and whatever, but like, how is that, how are going to people really implement this in their own setting? And that's very dependent on what resources they have and what's going on. What's the experience of the patient as they walk through that health system? And so we kind of took the interviews and coded them to try to figure out what were some common themes that came up. And you can see here, I'm not going to read them to you, but really a lot of it was around, like, at the beginning of the process, why was there delayed presentation of care? What were the issues with the care that was happening in the ED? Was it lack of knowledge? Supply, space, and then finally what happens afterwards, because the emergency department is only a small piece of their visit, right? If they get admitted to the hospital, what happens after that? And what are the what does that mean in terms of limitations for caring for a child moving forward? So those are some of the things that we saw came out of our needs assessment and helped us to develop our curriculum. Go ahead.
Great. And so the next step for curriculum development is going to be, developing your goals and objectives. And so it's important when you're developing these objectives, you should be really thinking and asking what you want your participants in the training to walk away with, or what do you want them to be able to learn to do? Like, what skills do you want? And so you need to make sure your goals need to be general. They need to relate to the curriculum and knowledge and understanding of the people you're going to be training. Your objectives have to be SMART, so they have to be specific. They have to relate to the learner, measurable, and you have to be able to, ideally, you're going to be able to measure demonstratable behaviors. And so obviously, I think many of you are aware of the SMART mnemonic for SMART, measurable, action-oriented, realistic, and time-framed. And then your goals and objectives should be linked to each other. And so this is, we use this framework to develop the learning objectives for the Botswana EMS course. So if you take a look at one of the prioritized needs, which was to enhance the skills in newborn resuscitation for the Botswana EMS program, for each of the learning objectives, we would develop cognitive, technical, and behavioral objectives. And what we see here are examples of each for this neonatal resuscitation training. The cognitive skills are generally thought of as knowledge-based, whereas the technical skills relate to specific skills learned, and then the behavioral aspect relates to the future changes in practice of your participants, kind of what you're aiming to have them learn long-term. The next step in the curriculum development is going to decide how you want to teach this material, like what type of modality do you want to use. So you need to develop a detailed plan of instructional methods that will best achieve the goals and the goals and objectives as set out by the team. And for example, simulation is one possibility for an instructional type method. With you have multiple different simulation modalities that are available to you. So for us with the Botswana EMS project, simulation was chosen as the main educational modality for the training, because we felt it offered we know that there's evidence that it shows that this offers healthcare providers an effective way of developing clinical knowledge, different procedural skills, teamwork, and communication. So while we decided that simulation was going to be our main modality, we also felt like we had to do some didactic sessions. We tried to limit those and make sure that they were really brief and focused didactic sessions where we didn't just want to be standing there talking to the trainees. And then we also had hands-on skill stations as part of the training and education strategy. So once we decided on simulation, we chose a specific type of simulation training we wanted to do based on the available resources in the country. There are many different types of simulation, such as high fidelity, your low fidelity. You have task trainers, actual sim patients, virtual reality. But our focus, based on the resources available, was on low fidelity simulation and using task trainers for the skills training. And so the Texas Children's Educational Grant at that time allowed us to purchase or fund adult and pediatric and infant simulation mannequins and different skills training equipment for this training program. And much of the ancillary equipment, such as IVs or like IV bags, all the other equipment was donated or expired equipment, either from Texas Children's or from our Botswana Ministry of Health colleagues that we would use and reuse for future trainings. So there are a few different ways to conduct simulation training. You have feedback and debriefing. That's the more traditional, like basically letting teams go all the way through a sim scenario and then evaluate how they did. There's deliberate practice, which is more, purposeful and systemic repeating. You basically stop sim scenarios and provide teaching points and then restart again. And the idea, you're building on key critical points and adding on complexity as you go. And so we decided as a group that we would use rapid cycle deliberate practice, knowing that many of the EMS workers did not have any background in pre-hospital. So we wanted to go ahead and correct as we went through these scenarios. So regarding the implementation step for the Botswana project, we made sure that we had political and key stakeholder support for the curriculum. Again, I can't stress the importance of this. Just like, as you're developing your needs assessment, you're developing your relationships. You need to do this in collaboration with your stakeholders, including, in this case, the Ministry of Health. So we didn't want to do this siloed. We wanted to make sure that we had the support of the Ministry of Health as we move forward with this project. Certainly, you needed to identify and procure all the required resources, identify and address any barriers to the implementation of the project, and then pilot the curriculum and train the trainer. So again, as I mentioned before, I did not, nor anybody from the Texas Children's team, wanted to be, or felt like we should be the ones up doing the training sessions. We wanted to train individuals that work within the pre-hospital program in Botswana to be trained to train the other staff. And I think this was a critical step. And then the next step after you've done the trainers and you've piloted the curriculum is really to administer it to your target audience. And then you refine the curriculum over successive cycles. I think the more you do the training, I think you recognize that, some things need to be altered or added. So, we started off by conducting the trainings throughout the country in 3 main Ministry of Health EMS centers in the country. An important component of the implementation for the Botswana project was to ensure the sustainability of the program. Again, as I mentioned, the trainers is an incredibly important step to take. So you make sure that there are people that are there to continue to do the training once you leave. Hopefully the goal is that, this program will then continue on without you in the long term. So the way we conducted the trainings, the large group trainings were 2 days long. They had a mix of, as I mentioned, lectures, sim scenarios, skill stations, and then we had final testing sessions, both written and simulation. And then all participants received a certificate of completion from the Botswana Ministry of Health upon finishing the program. So in regards to evaluation and feedback of a project, it's incredibly important. And really you start to think about how you're going to evaluate your project in the beginning or early on. And so how are you going to measure your successes in your program? It's nice and easy just to hold a training and pat yourself on the back and think that, you made a big difference. But I think it's incredibly important just to go methodologically to go through and make sure that you are evaluating all the steps. So Kirkpatrick, this is a very well known and published evaluation model for training programs. There are 4 different levels of Kirkpatrick's evaluation. The first step is, and it's kind of a stepwise project or progress as you go up this pyramid. So step 1 is just the reaction. This is like baseline, just asking your trainees via self-assessment, did I get what I wanted out of the course? Do I feel more comfortable with X skill, et cetera? And then the next step is going to be learning. And so this is assessed via pre and post tests. And so this can be a written test. So we did that as part of the Botswana program, but we also did a simulation skills session pre and post test. So we would have testing scenarios where we would evaluate the learners as they went through those specific scenarios. And then, after the next question is, behavior. Have they been able to apply what they've learned into a real life setting? This is definitely more challenging to measure, but we did this by analyzing the EMS written patient report forms that are filled out on every response call. We looked at those to see if the team is utilizing the skills taught, and I'll talk a little bit more about this in just a little bit. And then the highest is, results. And so this is by far the most challenging level to attain as far as your evaluation. And the question here is, have you effectively, changed morbidity or mortality based, due to your training or intervention? There are many different challenges in getting to this level. Some of them are based on availability and quality of the data. For example, for the Botswana project, all of our charts, both in the hospital and pre-hospital setting, are paper-based. So there are inherent challenges at the time in doing prospective, longitudinal, and retrospective studies to see if there was any change in morbidity and mortality after the training. So just something to consider as you develop your project is how you're going to attain and evaluate all these levels if possible. So when looking at just examples of these different levels, so for self-efficacy, so when we looked at provider confidence, pre and post training, we noted an overall improvement of 15.5%. For our pediatric knowledge base, for the pediatric content, when comparing pre and post simulation scenarios, we found the average changed by about 21%. And for the written test, we saw an average improvement of 10%. For the adult test, we saw simulation scenarios improve by 33%, and the written test saw an improvement of 18%. So as far as our behavior change evaluation, our plan on this was to review these patient report forms completed by pre-hospital providers and compare those response calls pre and post training. So we did a power calculation for the sample size and then reviewed these patient report forms. Again, these are paper forms that you have to go through, very, very laborious, completed by the Botswana Ministry of Health EMS providers who participated in the training. And the goal was to evaluate specific tasks completed by the providers as recorded on those patient report forms that are filled out on every single response call. And so for us, we reviewed 348 patient report forms from 6 months prior to the training and 350 forms from 6 months post-training. And we looked at 21 separate actions that were evaluated, or those that were taught in the training and able to be recorded on those patient report forms. And we found an improvement of 9 out of the 21 actions that an EMS provider can do and can record on those patient report forms. There was a significant improvement in taking vital signs. It sounds very, very, basic, but this was incredibly important and something that was not necessarily done pre-training. And then we saw an improvement in documentation, past medical history, and then improvement in the treatment actions that were shown in the chart. And then for the initial assessment, we really didn't see any significant change. All actions like assessing airway, breathing, circulation had a 98% completion rate pre and post. And for history taking, they had about a 96% recording of the presenting complaint and allergies pre and post. For the treatments that were available, we had a very low rate pre and post for airway intubation, suctioning, bag valve mask ventilation, CPR, defibrillation, oxygen intervention. Again, these were tasks or skills that were rarely performed based on the treatment algorithms and equipment available to the EMS providers. So, the limitations of, this behavioral change evaluation for this specific study there were multiple challenges. We had multiple different team members that were on response calls, and it's possible that an EMS provider who was trained was not the one documenting. And then in July 2016, we also had a change. The patient report forms that the EMS providers fill out, they changed the format of that form. And so to counter that, we just looked at both the pre and post patient report forms and we only collected data that was present on both. And again, as I mentioned before, these are all paper-based. So we had some patient report forms that were missing. So, in conclusion, the simulation training for Botswana has definitely increased provider confidence in the management of pediatric and adult presentations, improved the provider knowledge, and may have influenced an improvement in pre-hospital provider care, and was definitely associated with enhanced compliance with documentation of pre-hospital actions. I think the different opportunities we have are to focus on areas for us to focus on our areas of weakness identified in the training and investigate why some procedures were not being performed. And then certainly something we've done is expand the training curriculum. To date, there have been, over 30 different trainings throughout the country in 10 different Ministry of Health EMS stations. Our lessons learned, certainly we know the importance of developing an educational curriculum takes time. Don't take shortcuts. Overall, there are limitations of the program and with this program and lessons learned really to plan for the unexpected. In 2020, we had the COVID pandemic, and this provided really significant challenges to our program in that the Ministry of Health reassigned about 3/4 of the pre-hospital staff to different roles within the healthcare system. So leaving very few trainers left to continue this program. So kind of constantly being flexible and thinking about different ways that you can change your program and adapt to challenging situations. Certainly, we felt simulation is an excellent hands-on approach to teaching. And we can't stress enough that it's important to have your local staff to conduct the teaching, to do the trainers. You need to plan for evaluation of the curriculum and utilize technology that's appropriate for the setting that you're working on. And then really make sure you have a dynamic and interactive process. You don't want to stand up and just do all didactic lectures to them. So as far as our next steps with the Botswana program, we're continuing to expand the simulation curriculum. We initially thought we could do a train the trainers and rely on those initial trainers to carry the program forward, but we've realized that we need to do this train the trainers on a more regular basis based on changes in staffing. And then certainly, continuing to find funding for additional simulation equipment, which breaks down over time. And so making sure you have a plan for that going forward. We've also developed a community-based EMS program, looking at how we can get non-trained or basically community members to help as first responders within communities in Botswana. And now, Carol, go ahead, take it away with the AFEM project.
Okay, great. All right, so just talking through, which you'll see a lot of threads of similarity with Nick's project as through ours, kind of speaking to kind of having that process. But so for the AFEM project, our training was conducted over 2.5 days, and this was kind of our pilot implementation. So once we developed the curriculum, obviously, and we did the needs assessment. We talked about how to sort of create it, what learning methods, what goals and objectives we wanted. The next step would be to pilot it, and so we did it in like I mentioned, Tanzania. It was a combination of lectures, skill stations, and simulation scenarios based on the needs assessment that we did. It was felt to be the easiest way based on the needs of the people. And then we had about 15 nurses. So this tier 1 curriculum was actually, so to give you a little more background, we created a couple different tiers of this curriculum targeted at different cadres of providers, recognizing that in a lot of settings in sub-Saharan Africa, a lot of the medical care is actually delivered by nurses, and having a physician deliver the care is actually, or even by pre-hospital, for example, as Nick pointed out, but having it provided by a physician is actually, you're not going to see that at a lot of centers. And so this tier 1 curriculum is targeted for nurses. And we had 15 nurses participate who are matched to controls. And for evaluation and feedback, not going to belabor this, but similar to Nick's sort of Kirkpatrick levels, we looked at self-efficacy surveys, knowledge tests. And then in terms of change in behavior, we actually looked at, we observed these providers during resuscitations of pediatric patients. And then we actually had our research assistants kind of use checklists of whether they performed certain critical actions or not. In terms of outcome, the fourth outcome, which Nick mentioned, is the hardest. We were hoping to look at pediatric overall mortality coming out of the emergency department, but unfortunately, that for a lot of logistical reasons just wasn't possible. So a lot of the things that he's already mentioned, but something that you have to think about when you conduct your own projects going forward. But also, I think thinking about what is your ultimate goal, and sort of thinking through, okay, what is it that I really want to show through this? And then finally, we did some interviews of participants. Next slide, please. All right, so here's just some photos showing our tier 1 training. here you can see this is Raya Yusuf. She was one of the residents and is now a emergency medicine physician there, who's doing some of the simulation. And this is Kalalo and Gemma, who's one of the graduates of the first class. Go ahead, next slide. All right, so you can go ahead and just click through this. Thanks, Nick. Oops,
Sorry.
not that far. That's all right. So you can see from our tier 1 pilot, just to give you a summary. So we did see improvement in self-efficacy as well as knowledge after the training. But when we looked at our critical action checklist, we actually didn't see a whole lot of significant change. And then, as I mentioned, our 48-hour mortality, that was not something that we were able to collect data on. And I'll talk a little bit more about this, but let me first talk. So tier 2. So tier 2 training was targeted more at sort of your registrar level. So these are people who have finished medical training, but necessarily haven't done a residency in a specialty. And we decided, it's just a slightly more advanced curriculum, because obviously the expectation is that you were taking care of sicker kids. So that's not always true. And this we did in partnership with JFK Hospital in Monrovia, Liberia. And so similarly, it was a combo of lectures, small group, activities, skill stations, and simulation scenarios. And we actually did it with the country's interns and residents. So there were 36 total. We did not have any controls because there are no MORDOC. That's all that they have in the country that are training. And the agreement with their Ministry of Health was that we would train everyone. So we didn't really, it wasn't like we could hold back training and have a control group in this particular scenario. And we used similar measures for evaluation and feedback, our surveys, our knowledge tests, critical actions, as well as interviews of our participants. And this helped us get also another site out of, because, Tanzania is in East Africa. And so this is a site in West Africa to help with a little bit of geographic variability as well. Next slide. Thank you. So here's some photos you can kind of see. These were our groups that were getting the teaching and the training in Liberia. All right, and then as you can see, these are our results. Again, we're seeing improvement in self-efficacy and knowledge after the training, but no real change in performance of critical actions. And again, we're not able to collect the 48-hour mortality for many logistical reasons. Next slide. Okay, yeah.
Great. And, something just to also keep in mind as you develop a training curriculum, if that's what you become involved in, it's incredibly important just to disseminate the information and knowledge that you've learned, not to check off, so that you yourself get published, but you want to be able to share these curriculums with others and make sure that lessons learned from your curriculum can be shared for others, and they can adapt. We shared the actual curriculum that we developed, including the simulation scenarios, and so that anybody can reapply or apply those in different settings. And I think Carol, yeah, go ahead. Carol did the same thing. Yeah, go ahead. Sorry.
Oh, no, yeah, similarly. Just want to really it's really important to disseminate what you've learned so that other people can learn. Yeah. I'm sorry, I got distracted by the chat question. I think I have a slide on this to talk about there is no real change, but in case there's not, I will, because we've changed around some of those slides, I will definitely answer that question at the end. Here we go. Okay, so so here we were after we did tier 1 and tier 2, and we were kind of reflecting and we're thinking, okay, what have we done? Where have we been? And I think this is a really important step too, after you've sort of launched. Sometimes you get, you're kind of in this cycle of here are the different steps for the process. We'll just keep going, one through one. But I think stopping and really thinking through, okay, now what does this all mean for us? And what lessons have we learned, and where do we want to go now is critically important. So as I mentioned before, so one of the things we had sort of reflected on was we had plans originally to do 3-tiered curriculum. So tier 1, tier 2, tier 1 is sort of the nursing and pre-hospital group. Tier 2 was sort of for the for our registrars, so a lot of our interns and a certain maybe early residents. And then tier 3 was really meant for sort of the subspecialty kind of group. So what we would expect for, say, like a PEM fellowship, for example. I think when we really sat down and sort of thought about it, we thought, you know what, does that really make sense for this setting? Because that type of provider, at least for now in sub-Saharan Africa, as I pointed out, is it's pretty rare. And so, putting all, I think focusing more on training up the groups that are there became more of a priority. And so we decided that instead of doing putting time and energy toward a tier 3 curriculum, we wanted to put more thought into seeing why we see this change in confidence and knowledge in our providers, but not necessarily in behavior. And so I think that's what we're kind of going through now. It was a study that was started during the pandemic, so obviously got slowed down, but now is still happening. But it's a qualitative study where we're interviewing providers across different parts. We have different regions of Africa that we sort of split up in sub-Saharan Africa, and sort of we're trying to interview a certain number and a certain from every cadre to kind of get an idea of, like, is this way that we're teaching actually helpful? Because even though, like I said, we're seeing changes in self-efficacy and behavior, but not necessarily in knowledge, but not necessarily behavior. So thinking through, is this the way that we should be doing this? Is there another way we should be doing this? Is it the fact that we need, and as Nick mentioned before, do we need more refresher courses? Do we need more? Is there just too much turnover? Is that what's happening? So really try to figure out really what is it? Is it something about how we're teaching in these settings that is, or the curricula that's being put forth in these settings, not necessarily us teaching, because as Nick mentioned, we always have local teachers, but what is it about that process that we could be missing? And so that study is kind of ongoing right now. I will say some of the reasons that I can, at least for our specific studies, I think part of the problem was some of the critical actions were recognizing that kids are, let's say you have a kid in respiratory distress, let's put on oxygen, or recognizing that a kid is in sepsis. And in a real life, resuscitation scenario, it may not be something that somebody states out loud. This child is in respiratory distress. This child is in sepsis. And so, it may be that's simply how these actions were missed, for example. So I think those are some thoughts around why it could have been, but I think, again, we have to take a closer look to find out. Did that answer your question, Renee? Okay. So moving on.
Yes, thank you.
Oh, okay, great. So moving on, I just had this slide here to talk a little bit about what Nick mentioned earlier, which is really important, which is bidirectional partnerships. And I think, one thing we may not always remember is that when we talk about low resource or resource limited settings, I think sometimes we forget that this extends to include human resources as well. It's not just medical supplies or whatever it is, training programs or whatever. So oftentimes when we are working with our partners on the ground, our key stakeholders in the different settings that we're in, like they are often working like 10 times more jobs than you are working or I am working. And so a lot of times they're very strapped in terms of being able to assist with certain projects. And so I think just recognizing that is really important to understand why, sometimes I hear people say, I'm not getting responses to my emails, or I'm not, people are not making this as high a priority. And I think, a lot of that comes from this, like from this fact. This photo here is of Dr. Upendo George. She was one of the first emergency medicine physicians in Tanzania and was the head of the pediatric emergency department at Muhimbili in Tanzania. She was my primary partner on this project and a close friend. Unfortunately, she passed away during the pandemic. And so she is very sorely missed. But I put her picture up to kind of give an example of a situation that came up with this, and I'm sorry, I know we're running out of time, but when we did this, when we launched this tier 1 training pilot there, she was actually supposed to be the primary instructor, but the hospital had a lot of different conflicting priorities at that time, and they actually pulled her to do a different training instead. But because the hospital had made this project a priority as well, obviously, because we had shared that priority together, they identified somebody else who ended up being Kalalo and Gemma, who's the one I showed you in the picture, who actually did a lot of kind of led the training on those days. So I think this is just, and this all happened like literally the day I arrived in Tanzania and got on the ground, and when we were ready to launch everything. So just an example of why making sure that your priorities are truly reflect the priorities of the group that you're working with, and then making sure that you stay flexible, I think, is the other thing. So and then this, I think, last slide. So, and I think this, again, so aligning priorities, making sure that we benefit both sides, making sure that you stay flexible. And then lastly, and Nick kind of mentioned this already, alluded to this, but using your superpowers to advocate for your partners. So making sure that you're including everyone on publications, on dissemination, on making sure that people have sustainable support. So when you're asking for research support on the ground, when we hired our research assistants, part of that was being able to invest in helping people get that infrastructure there. And as Teresa well knows too, like, how do you maintain that? Like, how does a group maintain supporting someone's research infrastructure once your project is done or another person's project is done? So just really helping to advocate for your partners wherever you go. And then also, sorry, before we go to this slide, just the last thing is just remembering power dynamics can really prevent people from feeling empowered, to be honest. I think that's true in our society, but also I think as we work cross-culturally, I think it's really important to recognize that. And so sometimes people are trying to be agreeable, to be polite, but I think, so again, just really important to recognize, and I think this is where your relationships with your stakeholders, if you really understand them and know their setting and know them, I think you understand that as well, what they need. Sorry, last slide.
Yeah.
Go ahead.
This is the last slide. Go ahead.
Okay. So just thoughts about building a career in global health, and Nick, please jump in here, but there's so many global health communities. Find yours, be there. All these are all groups that have global health societies that you can join. Network. Find your mentors, get into projects, really build and invest. And the last thing I would just say about that is just do whatever you say you're going to do, because I think there are a lot of people who say, and trainees especially, who say they want to get involved in global health work, and then they're busy, and obviously we all have things to do as you go through training, but it's just making sure that you do what you say you're going to do as well. So
Great. Well, I know we were a little short today, and we're probably at time right now, but we can maybe take a question or two, or do we want to do that via email, whatever you prefer?
Yeah, we can take a couple questions, and we'll also put in the chat the link to the survey for feedback. So if you guys don't mind taking a minute to fill that out. Any questions?
I feel like this was kind of woven in throughout your presentation, but I would love to hear your explicit thoughts on how you really built the relationships that you have, like with AFEM, for example, and like leadership in Botswana. And then once you start investing in the project, how you really get your foot in the door with the Ministry of Health. And obviously you talked about how it's very time intensive, very, very labor intensive. Like, who was actually the folks on the ground that were doing a majority of this work? Was it y'all using your global health time? Was it folks that you were hiring locally, or just really great buy-in from local staff? And in addition to that, funding, how did you find the funding to do your projects? Long question, sorry.
No, those are great. All great questions. I mean, as mentioned, I think that It is a huge time investment. I think the time you spent in the beginning is invaluable, and that time is the importance of that time is you developing relationships and gaining the trust of the stakeholders that you're going to be working with. And part of that is meeting with, upper level people, in my case, with the Ministry of Health, in Carol's case, with AFEM, and making sure that you have that level of support. And you're not like going back to them after the fact, after you've done the training. You're letting them know every step of the way that, this is a problem that's been identified. These are the results of our needs assessment. This is how we're going to develop this curriculum, and keeping them involved every step in the way. This is incredibly time intensive. Fortunately, through our fellowship in global health, the combined PEDS emergency and global health fellowship at Texas Children's, we had approximately 3 months every year of a 4-year combined fellowship program in which we could spend abroad. And so those 3 months a year, so I typically would go for about a month at a time, come home for a couple months, and then go back again. So you obviously are not on the ground continuously throughout the year, but you're showing up for a month at a time throughout. We had the advantage of doing that. And so it allowed to, develop those relationships. I think with Zoom and, I think one of the benefits that came from the pandemic and the ease that could be kind of a double-edged sword, but the ease in which we can do virtual connections by video, can also help to improve your presence in developing relationships. And in regards to grants, I think looking around at what might be available through your own institution. I know Texas Children's had specific, education grants that you could apply for. And these are kind of like seed funding grants to get your project going. And then, other grants like Carol through like the Hellman or Doris Duke. There are many different opportunities. It's not incredibly easy to do it. I think there are some challenges in trying to get grant funding for an education type program. A lot of the grant funders are very disease specific. And so if you have an opportunity to somehow tie in your educational curriculum with a specific, endemic disease like malaria, whatever it is, I think there tends to be a bit more funding available for disease-focused projects. Now, your education project can have part of it focused on that disease, but you might prioritize it. So understand who your funders are, and what their priorities are is incredibly important. Carol, anything else?
Yeah. No, I think Nick, you did a really nice summary of that. I would just say, to get your foot in the door, I think you gotta be there, so you gotta just like I said, be present, network. Like I said, it's a good way to start out with these societies that, that are US based, that, if you want to go in and show up, but put your name out there, tell them people that you're interested. There's always, global health is not well funded work in general. So everyone's looking for free labor all the time. So I think that sounds terrible, but it's very true. So I think, if you're willing, like if this is what you really want to, if you find something that you're really passionate about, a specific project, show up and tell people that you're interested, and then do the work. And I think that will help kind of get you established. And then as you move forward, through these projects, if the priority of the project is aligned with what your partners on the ground really do want and really find to be indeed a priority, then those are your connections. That is often the Ministry of Health, and that is often whoever else already has those connections to get you sort of what you need to the higher levels. Like I said, for our curriculum, it was all the AFEM members got together and decided that this is what they wanted. So this came from the top down. So I think, implementing something that comes with that kind of a mandate is a lot easier, again, than trying to come up with something that you think might be important, but maybe isn't, or your partner doesn't, or isn't ready for, because I think they have to be ready for it at the right time too, it's a lot of work to do an implementation. And then I think in terms of, you had a question around who does the work on the ground. I mean, I was, like Nick said, we go for periods of time and long periods of time often, but a lot of times, like I said, if you have your partners who are committed to, then they can help you do a lot of this work on the ground as well. You should not be a one-man show or one-woman show. It should always be with others. And then the funding piece, yeah, I don't have much else to offer on that one except, yeah, look for internal grants. I will say some of this isn't as bad as you think. When I sat down with in Tanzania to go through the budget for what it would take us to do this pilot in terms of like the implementation, the evaluation, the research assistant time and whatnot, like when I actually sat down with the ED managers and went through the whole budget, it can be sometimes more affordable than you would necessarily do this if you were doing this in the US. So I think sometimes sitting down and coming up with the exact numbers and then helping to and that'll help you kind of direct how much money you're looking for. And sometimes the smaller grants, when I say smaller, meaning 25, 50 or whatever thousand, then sometimes those can be enough to at least get you started.
Thanks for the presentation. I hope you can hear me. It was great to see, especially Liberia and JFK. That's where I trained and worked for a couple of years. So it's great to see that. My question is around collaboration beyond the Ministry of Health, especially in terms of sustainability with the educational institutions and the educational ministry. Like, how do you collaborate, whether y'all did any collaboration with those institutions and even licensing and accreditation bodies to make sure that this training is sort of adapted at the multi-sectoral level and not just, because I think oftentimes that's the problem that happens when the collaboration is only with the Ministry of Health and it happens at one point, but it's not absorbed into training programs and licensing programs. So just curious to hear about that. Thank you.
Yeah, that's a wonderful point. We in particular with the Botswana project, we did not involve the Ministry of Education. What we did do over the years, like I think it was in 2018, Botswana developed or opened the doors to its first EMS college. And so it was a private institution. And what we did is collaborate with them by sharing our essentially BLS curriculum for EMS providers to allow them to easily adapt that for their training. I think, certainly involving the Ministry of Health makes a lot of sense, especially when you consider sustainability. It's just something that we did not do with our project.
Yeah, I was going to say, I think ours was a little different because it was actually for AFEM. And so our tier 1 curriculum actually is published on the AFEM website. And the idea was to make it something publicly available for use across the continent for anybody who wanted to take it and adapt it, which is oftentimes what happens with a lot of the AFEM curricula, is that certain countries will take parts of it and adapt it to their specific setting for their educational needs. So we did not target any one specific country or Ministry of Health. I mean, we did for the pilots, but for the overall curriculum itself, it was the end goal was to make it publicly available online for people, which it is, for people to download and use. But I think it's an excellent question. I will say there is some talk of developing pediatric emergency medicine and critical care fellowships in other countries in East Africa, like in Rwanda, in I know Uganda, I know, Nick, you've talked to some people there, and I know Tanzania is seriously thinking about it now, following kind of the footsteps in Kenya. And so there is talk of creating sort of a large regional East African sort of accrediting body, since there are so many different institutions who are looking to do this. But I don't know, that's all I know is that there's been talk of it. I don't know that there's any work actually gone forward on creating these types of accrediting bodies.
Thank you.
Thank you both very much. It's always very inspiring to see your work. So thank you for taking the time out of your day to come and present to us. Appreciate it.
Absolutely. Our pleasure.
Thank you.
Thank you.
Have a good rest.